Well, I'm Patrick Myers, Associate Editor for CTSNet. We're at the STS 2019 meeting in San Diego, and we're here for this roundtable on advances in arterial grafts in coronary artery bypass grafting. I'll let my panelists introduce themselves.
Good morning. I'm John Puskas at Mount Sinai Heart at Mount Sinai St. Luke's in New York City.
Mario Gaudino from Cornell Medicine, New York.
And I'm the non-New Yorker here. I'm Mike Mack. I'm the chair of the cardiovascular service line of Baylor Scott and White Health in Dallas.
So we previously talked about making veins great again. We'll talk about arterial grafts today. Now, the current state around the world in CABG is that arterial grafts are not used as much as they're recommended. What does our panel say about that?
So I think despite some pretty compelling evidence that multiple arterial grafts lead to longer term survival than single arterial grafts, the practice does not match the evidence. And I think there's a number of reasons for that. I think one is that surgeons are reluctant to get out of their comfort zone. And the comfort zone is a mammary and 2 or 3 vein grafts. Number 2 is we have not focused on coronary revascularization as a specialty like we have with other procedures in cardiac surgery, such as valvular heart disease, mechanical circulatory support, transplant, thoracic aortic. And I think that if we focus more on having coronary specialists, then we would see adoption of evidence-based medicine be greater than what it is right now.
Okay, thank you very much.
Now, what's your opinion there?
Well, you know, I think that we see a tremendous gap between the evidence base and common practice. And I think that we as a specialty need to own up to that. The comparisons, for instance, between PCI and CABG were done in very well organized trials. And in those trials, the vast majority of coronary bypass patients received 1 arterial graft and 2 or 3 vein grafts. And yet we still, generally speaking, beat PCI. And those randomized trials are what power and inform the guidelines and shape our careers and shape our profession and shape the care provided to our patients. Had we as surgeons done 2 or 3 arterial grafts in each patient in those trials, the guidelines would be different. Care provided to patients worldwide would be different. It's on us to do the best we can for every coronary patient. And to be honest, the best we can in 2019 is not the same operation that was best in class in 1980.
Didn't you just publish a paper on the outcomes of cardiac surgery or CABG in Excel versus Syntax? And haven't the outcomes of coronary bypass surgery improved between those 2 trials?
They have somewhat. I think that we are gradually upping our game. But I think we can do better than we have. Mario and others published a paper looking at arterial conduits where the second arterial conduit is not a second mammary but a radial artery, and it impacts survival in a dramatic way. We saw from the ART trial, which we should talk about today, that we're not as good as a group of surgeons at harvesting 2 mammary arteries as we thought we were. In the ART trial, which enrolled 3,000 patients in 20 some odd countries, 14% of patients assigned to the double mammary group actually got a single mammary. And these were at centers that volunteered to participate in this trial. They considered themselves expert double mammary grafting centers. 14% of the time, 1 in 7 patients got a single mammary instead of a double mammary, for whatever technical reason. We've got to be able to do better than that in common practice, and I think that that's going to require specialization, special training, special attention to detail, perhaps even a network of advanced coronary centers that you and David Taggart talked about in a recent editorial. Mario, what are your thoughts on arterial grafting? You've published a great deal on this. There's probably no one around that's published more recently on this topic.
Well, thank you for that, John. Well, those are all great points. I think that now we have really solid evidence. You was mentioning Radial. So, you know, in the past, there was a lot of criticism of observational study. We all know observational study can be biased. So some surgeons were saying that we did not know if there was a real clinical benefit for the use of multiple arterial grafting. Now, I think we have we start having randomized based demonstration. I think the art trial you was mentioning as a major methodological limitation, which are acceptable because that was the first large trial on the subject, so we probably learn along the way. But there is no doubt that now the fact that there is no evidence is not a justification anymore. I also believe that well, we cannot deny it's technically a little bit a more complex operation, and that's why specialization is needed. And I think the radial artery can play a major role in that, because you know very well the radial artery makes the operation easier. Mm-hmm. So I see the radial artery as the first step toward the multiple arterial grafting strategy. And I think surgeons who start using multiple arterial grafts, you should probably start from the radial artery. I remember your very nice closing of the 2017 International Coronary Congress in New York after 2 days where, I mean, the cutting edge, the top of coronary surgery was shown. And you told the audience, well, tomorrow is the most dangerous day for your patient, because after having seen all that complex technique around, you will be tempted to start tomorrow, and you shouldn't do that. So I think it's a process, and probably the radial artery will play a role in that.
So if I were going to ask coronary surgeons worldwide to adopt an easy stepwise approach to improving the quality of coronary surgery on the planet, I would ask them to add a second arterial graft for every case. And the easiest way to do that is to add a radial artery to a tight second artery target on the left side of the heart. I would ask them to perform intraoperative graft assessment. I mean, coronary revascularization is a vascular surgical procedure. CABG is the only vascular surgical procedure that doesn't have some kind of completion angiogram, some sort of a quality assessment prior to closing the patient. And yet it's the most important revascularization procedure. So intraoperative transit time Doppler graft assessment of the coronary arteries should be a must.
So what percent of patients get that done now?
In America, 17%.
17%?
17%. 83% do not. The flip is the case in some other countries, in Japan, for instance. We can actually detect that small percentage of grafts that will not perform well and revise them before we go out of the operating room. And it makes a difference. We're looking at incremental improvement, and it's something that's available now. It's easy to do. It's inexpensive. Those two simple mechanisms, I think, are really important. And the third thing I would say is we need to minimize aortic manipulation. Whether we're doing it on pump or off pump, there are available techniques to minimize aortic manipulation. In the on pump world, it's a single clamp with a shielded clamp, not a naked bare clamp. And in the off pump world, it's avoiding a partial occlusion clamp entirely and using either heartstring or other facilitating non-clamp anastomotic techniques on the ascending aorta, or a no aortic touch technique where there's really no manipulation of the ascending aorta, which has been shown to really truly minimize early post-op stroke.
So Mario, how compelling is the evidence for radial artery use? I've been around long enough that I've seen two waves of adoption and non-adoption and adoption again, and there is a reluctance out there for most cardiac surgeons to use radial arteries. They don't believe the evidence is compelling. They're concerned about the morbidity in patients. So, I mean, how would you state the case that more radial arteries should be used?
Well, this is all very true, but you know, it's very interesting that if you think about that, the radial artery is the arterial graft where we have more evidence. We have the 6 randomized trials that have compared the patency rate of the radial artery and the saphenous vein. We don't have that for the internal thoracic artery. And now we have a patient-level meta-analysis of randomized trial that show that the better patency rate is related to better clinical outcome. And in fact, the radial artery is the only conduit that has a class 1 recommendation in the recent European guideline. So I think there is no question that the evidence supporting the use of the radial artery is very solid. Concern related to the arm are understandable, but they are not substantiated by the literature. With careful preoperative evaluation of the ulnar compensation, there is almost no risk of ischemic hand complication. And I think the endoscopic harvesting technique can make, even for the patient, radial artery harvesting much more appealing.
So John, you mentioned that the incremental stepwise they would be to start using the second arterial graft in the radial. So if you're a surgeon that has been used to using just one internal mammary artery and 3 saphenous vein grafts, how would you tomorrow, changing your operation, what graft would you use and where would you put it? And are you concerned about competitive flow with radial arteries and all that?
Great question. So the most common operation in America is an on-pump, single mammary, 2 or 3 vein graft procedure. How do we improve that? The next step will be to remove one of those vein grafts and replace it instead with a radial artery conduit. And I would suggest that we put that radial artery to the second most important target coronary artery on the left side of the heart that has a reasonably tight stenosis. And then attach it to the ascending aorta with a small punch hole, again under a single cross clamp in your on-pump operation. Would not use it to a right coronary artery that has a moderate stenosis. Would prefer to use it to a big, tight obtuse marginal or a tight circumflex vessel. There are other more complex ways to deploy that artery to get multiple sequential grafts, but the first simplest step to improve the longevity of patients after coronary bypass surgery is to add a second arterial conduit.
And you wouldn't bring that off the mammary artery?
Not as a first step. No, I think the incremental improvement over a lima and 2 or 3 veins is a lima, a radial, and a vein in a standard configuration. Every surgeon in America can do that.
Now going over to the ART trial that was recently presented. Some very interesting results with 10-year follow-up now. In the intention to treat analysis, the results are not so positive. How can we put that into perspective? Is that telling us that we should not be using bilateral mammaries?
I think that's exactly the wrong take-home message, but some people will portray that trial that way for their own agenda. And as Mario said, the ART trial was designed a dozen years ago. It's now past 10-year follow-up. So it was a very early initial attempt to do a big randomized trial in double mammary grafting. And it did have some fundamental flaws in how it was implemented. But some of that was due to the fact that it's an old trial and we didn't understand the impact of radial artery grafts. So the intention to treat result in the ART trial shows no difference in survival between patients who were randomized to receive 2 mammaries or randomized to receive 1 mammary. But in fact, 36% of patients did not receive their assigned therapy, which of course makes the trial in some sense invalid from an intention to treat analysis. 14% of double mammary assigned patients actually got a single mammary. 2.4% of single mammary patients actually got a double mammary. 22% of patients assigned a single mammary got a single mammary plus a radial artery. Add it all up, almost 40% of patients got something meaningfully different from what the randomization had intended. But if you simply look at the outcomes and compare patients who got 1 artery graft against patients who got 2 artery grafts or more, the survival difference is dramatic, and it's very much in favor of better survival with more arterial grafts. That's the take-home message from ART.
So, but the trialist and the pure statisticians would say an as-treated analysis is not as valid as an intent-to-treat analysis.
And they are mathematically correct. That is true. There's no way around that fact. So that's where we come to Roma. Mario Gaudino here in New York and Steve Freems in Toronto have come up with a fantastic trial. Mario, you should tell us about it. This, I think, is the next logical step after ART and after the radial artery meta-analysis that you've done is to perform Roma, and you go off to a fantastic start with that trial.
Well, thank you for that, John. Yeah, basically, Roma start from art and from the lesson that we have learned. We have learned that first of all you need to control co-intervention. So now no radial, no arterial graft are allowed in the single arterial graft group. We have learned that crossover is very important. But we also have learned that the radial artery is probably as good as the right internal thoracic artery. So in Roma, we don't speak about one mammary, two mammary, or radial or mammary. It's just one arterial graft versus two or more arterial grafts. You can use the second arterial graft that you think is better for that particular patient or for yourself as a surgeon. Then methodologically speaking, ART was looking at the primary outcome, survival, but we know from the cardiology literature that probably failure to graft on a non-LAD territory is more likely to impact non-fatal cardiac events. So we have a composite of cardiovascular events. We are not looking at survival in particular. And then there are other methodological detail in terms of sample size calculation. So I think that you're right that the as-treated analysis is not as rigorous as the ITT analysis, but is probably a perfect background. ART is probably the perfect background to test the arterial graft hypothesis in a larger and better designed randomized trial.
So Mario, I would bet that there's a lot of people that will be viewing this out there that would love to participate in the Roma trial. Is that possible, and how do they do it?
Yeah, sure, it's possible because the trial has completed the pilot phase, and now we are entering the full phase. We have 30 centers open so far, but we need 60, so they just send an email to me and we'll start the process.
So we've just gone over a lot of very interesting data and interesting studies that are upcoming. Now, Dr. Puskas, you explained to us how each surgeon can add an arterial graft and improve the outcomes of their operation. What else could we do to incentivize surgeons to improve their operation?
Well, it's long been my belief, and it's not a unique thought, that the STS star system and quality metrics should count a second arterial graft as a measure of quality. That's more meaningful for patients than some of the other things that we presently count as quality metrics, as part of the STS star rating, for instance. Even if we choose not to put that in the star rating, we should at least have that be part of the STS report card. It should be elevated in its visibility. I think that would incentivize surgeons to reach for the higher mark. I personally think CMS has enough data to suggest that reimbursing a second arterial conduit would be money well spent. It will diminish reinterventions and prolong intervention-free survival in coronary bypass patients. It would pay for CMS and insurance companies to fund an incremental additional amount of money to pay surgeons to do that second or third arterial graft. Those two things would drive change more quickly than anything else, more quickly than the sage words of your panel. Money talks.
So I think those are great suggestions, but the three basic tenets of clinical adoption of any procedure or device are three. One is compelling evidence. And as you've heard from Mario and John, there is compelling evidence, but I would submit it's not compelling enough to move the needle for surgeons out there. So we have to continue to generate the evidence so that it is overwhelming and there is greater clinical adoption. The second is user friendliness. The second arterial graft is still out of the comfort zone of most surgeons. And with public reporting and the focus on CABG outcomes being so under the microscope now, surgeons are naturally and appropriately reluctant to change an operation that they do very well. And this is changing an operation, and they're appropriately very concerned about changing outcomes. So, we have to, as John just alluded to, as what the next step would be, an incremental step so that a surgeon is not out of their comfort zone, because that's when bad things happen. And the third is teachability. We've got to continue to educate on how to do the procedure better. And it doesn't matter what medical procedure it is. Those are the three rules of clinical adoption.
Well, we hope to fill some of that void with the International Coronary Congress. You have both been important faculty members in that enterprise. It's held annually. and it's the only meeting focused solely on the art and science of coronary bypass surgery. I noted at our STS meeting here in San Diego, there are some tremendous courses. 13 courses one could attend yesterday morning, repeated a second time later in the morning. 13 well-conceived, beautifully designed courses taught by world experts on such esoterica as minimally invasive mitral repair, per-oral esophageal myotomy, et cetera, et cetera. There was zero content in the courses. Not a single course of 13 had anything whatsoever to do with coronary bypass surgery.
Yet, by far, it's still the most common operation in cardiac surgery.
Correct.
So what's wrong with this picture?
Well, I think that we probably, as a profession, think we've got coronary bypass down pat and it's good enough. Yet, we continue to be eroded by PCI, and we continue to focus, as you pointed out, in response to the pressures brought to bear on us as surgeons, we focus on a 30-day outcome. And it's easiest to get a 30-day outcome with your standard operation. But for patients, we want a better 5-year outcome and 10-year outcome. And that's really where we have to focus our attention. What can we do to make coronary bypass a more durable operation, a more durable benefit for patients than PCI or any other therapy? That requires that we move outside our comfort zone.
So I know we're about out of time here, but let me ask you, I know you've also been a strong advocate for the hybrid trial. Where does that stand, and what's the logic behind that?
So the hybrid trial seeks to examine the question of whether patients who typically get double vessel PCI should instead get a lima to the LAD and a stent to the other vessel. So this is not randomizing patients who are normally referred for CABG. It's randomizing patients who almost always have multivessel PCI. And we randomize them to receive a minimally invasive lima to the LAD and a drug-eluting stent to the non-LAD target. The hope and belief is that the cardiologists will get behind it, and many of them have, because it actually doesn't cut into their business. They're still doing a diagnostic angiogram, then they're shooting the angiogram of the mammary, and then they're stenting the circ or the right. And that it will benefit patients, that the life-prolonging benefit of a lima to LAD will beat a stent in the proximal LAD or a second stent in the proximal LAD over a long term of follow-up. The trial is enrolling 2,300 patients. We're about 10% enrolled thus far. We've got a long way to go. We're now recruiting more centers. We have about 35 in North America. We're going to get about 50 in Europe. We'll have 100 centers before we're done. So we're very eager to have centers that are able to do an off-pump lima LAD, whether it's through a mini thoracotomy or robotically or even a limited skin incision and a sternotomy, and have a heart team culture at the institution where cardiologists will help to recruit these patients from the cath lab, because that's where they come from. So we're looking for more centers, and we believe that this will be another way to improve the care of coronary patients worldwide. Instead of stenting that prox LAD and the right, let's put a lima to the LAD and stent the right.
Well, thank you very much for all this compelling data on advances in arterial grafts.